Good morning, ladies and gentlemen. This is Aisha Shehi, a health coach from the National Health Insurance Company Daman, and I am part of the Disease Management and Population Health team. Thank you for joining us today in our webinar, Diabetes, where we are in 2022. The 14th of November is Diabetes Awareness Day, and this year marks 100 years since the discovery of the treatment that saved thousands of lives, which is insulin. In today's webinar, Dr. Sara Suliman from the Imperial College London Diabetes Center Abu Dhabi will take us on this journey. On a side note, please note that you can send your questions through the Q&A chat box anytime during the presentation, and we will allocate 15 minutes at the end of the session to answer these questions. Without further ado, please allow me to introduce our speaker for the day. Dr. Sara Suliman has MBBS in General Medicine, Diabetes and Endocrinology. She is a consultant diabetologist and endocrinologist, a clinical lead for obesity and metabolic bariatric surgery, clinical lead for the genetics of diabetes and endocrinology, and an honorary senior lecturer at Imperial College University, London, UK. Dr. Sara, welcome. The floor is yours. You may start now, Doctor.
Thank you very much for your kind introduction, and thank you all very much for joining today. World Diabetes Day is a very important day for us at Imperial College London Diabetes Centre and for Daman. And today I'd like to share with you how I feel that the future is bright, and together we can improve both care and control of diabetes. I have no disclosures. What I'd like to speak with you today is about the different types of diabetes, how we diagnose them, what complications can arise, how we can prevent them, what treatment options we have, share with you a little bit about the advances in technology, and my most important bit will be the last bit, which is how we prevent diabetes or cure diabetes. Cure is a very strong word, so remission is what we tend to say. Get rid of diabetes in people who already have it. So just to start off, diabetes is a group of conditions which are characterized by the inability of the body, or the pancreas specifically, to produce enough insulin. This can occur with or without the ability of the body to use insulin properly. So if we go back to basics, insulin, as you can see in this figure, is a key that opens each cell in our body so the glucose can go inside and be used. Glucose is the main fuel for our whole body. So if that key doesn't work very well, we will need to try more and more keys, hence the insulin resistance. And if we are unable to produce enough, then there are not enough keys for all our cells, and diabetes develops, whereby there's high blood sugar in our blood, but not inside the cells where we really need it. The symptoms of diabetes range from thirst, polyuria, or feeling that one needs to pass urine quite frequently, blurring of vision, and that's because the lens that we see through can be loaded with glucose, and therefore it becomes less mobile, and we can't see far and can't see close very well. Tiredness, as we explained, there's a lot of blood glucose in the bloodstream, but not in the cells, so we don't function very well. Interestingly, people with diabetes complain of hunger, even though their blood sugar is very high. And again, the cells that sense whether we have enough glucose or not do not have glucose inside them, and therefore they keep us hungry and perpetuate the problem of this high blood sugar. Poor wound healing because of the high glucose in the bloodstream that doesn't allow healing, and weight loss in people particularly with type 1 diabetes, and we'll speak about the types of diabetes. So in summary, most of the symptoms are due to too much glucose outside the cells, but not enough inside the cells. There are many complications of diabetes. Most of you will be aware of the ones on the right, the long-term or microvascular and macrovascular complications. The microvascular are due to the small vessel damage and they can result in loss of vision, they can result in kidney failure, or they can result in lack of sensation, either in the feet, the hands, or even in the gut, resulting in diarrhea and other illnesses. The ones that are most serious and lead to a reduction in the lifespan of patients with diabetes or persons with diabetes are the macrovascular or the big vessel diseases, and they include cardiovascular disease or diseases of the heart, cerebrovascular diseases such as strokes, and peripheral vascular diseases such as diabetic foot disease. The ones that can occur in a far shorter span, or the short-term complications, include those related to high blood sugar, such as diabetic ketoacidosis, where the body produces too much of an acid due to insufficient insulin and burning of fat. And that's particularly common in people with type 1 diabetes who have absolutely no insulin. Similarly, there is a diabetes hyperosmolar state where there's a lot of sugar in the bloodstream, enough to slow the bloodstream down and give effects of that, such as strokes or heart attacks. And that tends to occur in people with type 2 diabetes, often in elderly patients who don't drink enough, have an infection to precipitate it, or are not very well looked after personally or by their environment. I apologize about the split word. Hypoglycemia means a low blood sugar, and hypoglycemia that is serious only occurs secondary to treatment in patients with diabetes, and that can be tablets or it can be injections. Just to speak about the types of diabetes, so there are three main types of diabetes. Type 2 diabetes accounts for about 90% of diabetes. Type 1 diabetes accounts for about 5 to 10%. Gestational diabetes, or diabetes that's recognized in pregnancy, is becoming far more common, and we'll speak about it in a little while. There are many other forms of diabetes. Perhaps the most important of them are drug-induced, and some medications can cause diabetes, such as steroids and other medications, some antipsychotic medication being particularly likely to cause diabetes. And there are genetic forms of diabetes, but today we haven't got enough time to go into that. So type 1 diabetes is an autoimmune condition. What does autoimmune mean? So we have an immune system that protects us from bacteria and viruses. Sometimes it's a bit too clever, and it decides to choose bits of the body and produce antibodies against them, and therefore attack bits of the body. And that can result in things like thyroid disease or rheumatoid arthritis or type 1 diabetes. And in type 1 diabetes, the body produces antibodies against the pancreas and therefore destroys the pancreas, and the body isn't able to produce enough insulin. We don't quite know why this happens. It may be secondary to viruses, but the propensity or the predisposition has to be there. It's not a fully genetic disease. Even if you have identical twins, only 50% of them will both have type 1 diabetes, but there is a little bit of a genetic predisposition. The vast majority of type 1 diabetes, there is no family history. Approximately 10% of people are affected, of diabetic patients are affected. It often presents in childhood or early adulthood. And because the pancreas can't produce insulin, the treatment really is only insulin. Type 2 diabetes accounts for about 10% of the human beings on the planet. So it's a very common disease. It's 90% of diabetes. It is generally of a much higher magnitude in people above the age of 30. We say it's low below the age of 30, but actually, as you will see, it is increasing in childhood as well. And that's probably related to the increasing frequency of obesity. There are certain ethnic groups who have a very high incidence of type 2 diabetes. We are in a region which is one of these regions. So Aboriginals, Africans, Arabs, Hispanics, and people of Asian descent are disproportionately affected by diabetes. And approximately 80% of people with type 2 diabetes will have obesity or a large waist circumference. So even those who don't have obesity can have a large waist circumference. This is particularly genetic. So if someone has a parent with type 2 diabetes, there is a 40% chance that they will get type 2 diabetes in their lifetime. And if they have 2 parents with type 2 diabetes, that becomes an 80%. And if you have monozygotic twins or identical twins, then there's an over 85 to 90% chance that they will both get type 2 diabetes in their lifespan. But can we prevent it? I will show you later today that we can. So the steady increase in type 2 diabetes has been linked to the rising obesity rates, the sedentary lifestyle. So this isn't about just exercise, but it's actually about sitting down for very long hours, and the aging population. The thing I need to share with you is about 50% of people with type 2 diabetes in the world today do not know that they have it. So it's crucial that we look for it. Going back to the numbers, as we said, about 9% of the population of the world have diabetes today, and it's costing us a huge amount of money. So about 760 billion US dollars was spent on diabetes in 2019. So if we look at the whole world, not only is it a large problem, it is also rapidly increasing. So by 2045 in the MENA region, we're expecting an almost doubling of the number of diabetic patients. We look at the colours. The dark red colour is the countries with the highest prevalence of diabetes, and many of the countries in the MENA region fall in that group. And if we look at obesity data, we will see that this kind of mirrors it. It's therefore unsurprising that when people have looked at historical data, and this is looking between 1990 and 2000, the rise in the rates of diabetes in the United States has mirrored the rise in body weight, average body weight. And if you look at young, healthy females, so nurses between the age of 35 and 55, and look at the effective weight, you will see that those with a healthy weight have a relative risk of type 2 diabetes up to about 5%. Whereas if those who have a body mass index over 35 have almost 100-fold increased risk of diabetes. And again, if you follow up people for 10 years, and this is young men and young women, those who maintain or lose a little bit of weight have no increased risk of obesity, and those who gain about 10 to 15 kilograms in the 10 years have a 6 times increased risk of developing diabetes. However, not all fat is made equal, and this is very important. So not every obese individual is insulin resistant. And at the moment, the tool we use for obesity is a body mass index, which is your weight divided by your height squared. That does not tell us if you are a bodybuilder who's full of muscle, or if you're someone who has central obesity or a beer belly, like this lady on the left with apple-shaped obesity. They have a far higher risk of developing diabetes and cardiovascular disease than women who have a high hip circumference rather than a waist circumference. And then to go to the third commonest type of diabetes, that's gestational diabetes, which is hyperglycemia or a high blood sugar that is first noted during pregnancy. It is now recommended that every pregnant woman has to be tested for diabetes, not just with a simple blood sugar, but actually with a glucose tolerance test where we give her a drink and test her blood sugar at half an hour and 2 hours after, at an hour and 2 hours after that. In people who are known to be at high risk of diabetes or who have previously had gestational diabetes, this is done at the first visit. So when a woman knows that she's pregnant and goes to the doctor, it should be done then. And those who have no risk factors, and we'll speak about the risk factors in a moment, it would be from the 7th month or 24 to 28 weeks. The reason we do this screening is that if you treat blood sugar in pregnancy, then you have a far easier pregnancy for the mum. The baby is not very big, but also that baby is healthier. The risk of many complications, as you can see below, is reduced. More and more, we're looking at precision medicine, so looking at groups of people from an epidemiological point of view. What that means is looking at the whole population, looking at some clinical features, so family history, ethnicity, but also at diagnostic testing, and that hopefully will allow us to see who has a high probability of diabetes and should be tested, and also to subclassify people into those who will need insulin, or those who will need medication, or those who will need nothing. So in summary, diabetes is often a silent disease. 50% of people don't know they have it. It can result in morbidity or mortality, morbidity being significant illness, or mortality, which is death. But an accurate diagnosis is important in managing these people. And screening in high-risk individuals can improve long-term outcomes. So how do we diagnose diabetes? I apologize, I appear to have lost a couple of slides. Oh, they're coming, sorry. So how do we actually diagnose diabetes? The American Diabetes Association, which produces guidelines every year that are used by most countries in the world, have educated us on targets of a fasting glucose.
Doctor, sorry for the interruption, but can you please share the presentation again?
Is it not sharing?
Yes, it's not.
Can you see it now?
Yes.
Thank you. So just to say that the American Diabetes Association standards of care give us targets for a fasting glucose, a random glucose, which we sometimes use for people who have all the symptoms of diabetes. You can then test the blood sugar when they come to the hospital, because we don't want to send them away and say, come back tomorrow fasting. If we're doing the oral glucose tolerance test, which I described for ladies who are pregnant, then we test a 2-hour blood glucose and have targets for that. There is a very useful test called the HbA1c, which or sukar tarakumi, which is how much glucose is stuck onto your red blood cells. And because your red blood cells last for about 3 months, it's a really good guide to whether this has been long-standing or something that has recently occurred, and helps us in diagnosis. We can use one test only because it tells us about 3 months. So I mentioned pre-diabetes, and that is the area between being healthy and being diabetic. As we said before, we have a problem in that many people do not even know they have diabetes, so they're diagnosed, and there are many, many undiagnosed. But actually, in that iceberg as well is what we call pre-diabetes, that grey area in the middle. And the problem with that is that the cardiovascular risk, or your risk of a heart attack or a stroke, doesn't just switch on when you achieve the target to call you diabetic. It is a progressive thing, and therefore people with pre-diabetes have a much higher risk than people who are healthy. It's associated with obesity, it's associated with high blood pressure, associated with cholesterol, in much the same way that diabetes is. And if we look at targets, then it's that middle ground between what we described for diabetes. So for diabetes, it's over 126 milligrams, but for a healthy person, it's below 100 milligrams that a fasting glucose is normal. And that grey area between 100 and 125 puts you at that pre-diabetes level. Similarly, we can look at the 2-hour levels, and this is incorrect. It should say 5.5, so a normal HbA1c is below 5.5%, and between 5.6 and 6.4%, you have pre-diabetes, or one has pre-diabetes. So do we need to screen for these people? Do we need to find these people who have type 2 diabetes? So the criteria for any screening test worldwide to be successful are: is the disorder important for public health? Diabetes is. Is there an early asymptomatic stage? Diabetes does have that. Is there a suitable screening test? Yes, we can test for glucose and HbA1c. Is there acceptable treatment available? Because there's no point screening for something that you can't treat. Yes, there are many. And does early treatment actually change the course of that disease? And again, yes. So type 2 is definitely one of the diseases that we should be screening for. Who should we screen? And there are many recommendations. I'll highlight some. Family history, so patients with first-degree relatives with diabetes. We spoke about race and ethnicity, our area being particularly affected. Someone who's had a heart attack or a stroke. Hypertension, high cholesterol, and diabetes are best friends. So if you find one, screen for the others. Women with polycystic ovarian syndrome, and those who are physically inactive. Those who we have screened already and know have pre-diabetes, so in the grey area. Women who are diagnosed with gestational diabetes should be tested every year, or at the very least every 3 years. We used to say that we should start testing in every human being above the age of 45. That has now come down to 35 because we realize that actually there's a much higher risk in people between the age of 35 and 45 than we previously knew. And if your result is abnormal, then it needs to be tested either annually or every 3 years at the very least. There are simple calculators, many of which, so this one, for example, is from Diabetes UK. They're very simple. How old are you? Are you a man or a woman? Have you ever had gestational diabetes? Do you have a family history? Do you have high blood pressure? Are you physically active? And what weight category? And it gives you a score to tell you, should I go and be tested or not? And I would urge everyone here to go and use one of these calculators. And if they've not had blood sugar tests before, to go and seek blood sugar tests. They're going for free today in many regions, so it's a good time. So how do we treat diabetes? So there are, as we said, two main types of diabetes, type 1 and type 2. The mainstay of treatment for type 1 is insulin plus other measures. Type 2 is slightly broader. And the way I tend to describe it to patients is type 1 is like having a brand new Mercedes with no petrol in it. Don't put petrol in, it's not going to work. And that's your treatment with insulin. Type 2 is like a Mercedes that's maybe 20 years old, so sometimes it'll need a new battery or new plugs or something else. And therefore, we do need to actually service it regularly. We do need to use all the tools we have at the same time, including lifestyle, including tablets, including injections, and those with obesity, including bariatric surgery if we need it. So this is the historical way of how we used to treat diabetes. We used to say lifestyle change for 3 months, tablets, and then maybe insulin and tablets, and then keep on increasing the number of injections. This is the latest American Diabetes Association guidelines. I do not want you to read it, but all I want you to see is that they're now focusing on if someone has high cardiac disease, how do you treat them? If someone has a high risk of heart failure, if someone has kidney disease, how do we minimize the risk of hypoglycemia or low blood sugar? How do we minimize the risk of weight gain? And how do we consider cost and access to the medication? So it has become far more patient-centric. We've focused on the important things rather than what a doctor thinks should be a stepwise approach. The targets for diabetes treatment are equally tailored to the patient. So there is no point looking for very tight control in an elderly patient who lives alone because you have the risk of low blood sugars. And similarly, if you have a young person, nowadays your target is actually to have normal blood sugar, the same as a healthy human being, rather than a target. Deciding how or what target we have takes into account the patient's age, how long they've had diabetes for, their risk of having severe hypoglycemia, whether or not they have heart disease or kidney disease. We tend to be more aggressive with them, and their life expectancy. So if we speak a little bit about lifestyle, I know most of you today will want to speak about diet, but in summary, the diet that works for diabetes is the healthy diet that works for everyone else. And the best diet for a human being is the diet that they can do for the rest of their lives, rather than something that they can put in for a week or two and then will drift back. There are some things that are key, one of them being the sugar-sweetened beverages and highly processed foods. So sugar-sweetened beverages will include soft drinks or fizzy drinks. They'll include juices, including fruit juices that you make at home. So they have quite a high content of sugar. You've lost the fiber by doing that. I think across the board, the advice would be to try and replace them with water or healthier drinks. And in highly processed foods are things like cakes, biscuits, processed meats. There's lots of highly processed foods. The closer you are to how a food originated, the healthier it is for you. And if the specific dietary measures, should I go low carb, should I go low fat? I think dietitians are worth their weight in gold, and we don't have time to discuss that. We spoke about reducing the sedentary time, so the time that we're sitting and not up and active. It is encouraged that people at least every hour have 5 to 10 minutes of activity. So if you work in an office, stand up and have a walk rather than sending an email to the person in the office next door. Walk around and have a chat to them. Park your car slightly further away. That is very important. And the target is about 10,000 steps per day. Most of us have a phone or a watch that will track our steps. Exercise is different. And here the target is to build muscle, because muscle burns sugar. And we actively encourage people to do at least 3 hours every week of an activity that will build muscle. So either go to a gym or swim or cycle, and then there are many, many options. Sleep is crucial, and above 6 to 7 hours sleep at night makes a huge difference. So we would encourage people to, rather than have an afternoon nap, save their sleep time for nighttime and get good quality sleep. And there is fantastic evidence for that. The Nobel Prize a couple of years ago was given to a scientist who worked on circadian rhythm and the advantages on hormones and otherwise of the body clock. Adequate hydration, and that's drinking water, and the average adult needs about 2 liters a day of water. Those who do not drink sufficiently get an urge to look for sweet things or snacks, and it helps hugely when you're well hydrated. And obviously avoidance of other habits, which not only increase the risk of diabetes, but also increase the risk of complications of diabetes, such as smoking or alcohol. So medication, I'd like to touch upon. And again, if we look at, so we'll look at the tablets first, or oral medications. The first tablets actually came even before insulin, metformin, which is still around today, or glucophage is the name that most people know. It actually was discovered in the 1920s. It's a herbal extract. It works very well. The insulin, as my host has said, came in 1922 and overshadowed insulin, and therefore it wasn't used until again 20, 30 years later. We then have one class in 1942, another class in the 90s. We had quite a few appear in the 20s, and now we're getting a regular supply. I would like to highlight the SGLT2 inhibitors, which I'll speak about, which not only are useful for diabetes, but also reduce the risk of cardiovascular disease, heart failure, and kidney disease. So just looking at the current treatments we have, they work in different areas and have different functions. I will not go into the details, but if anyone wants me to do that at the end, I'll be happy to do that. This is the current range of medication that we offer at Imperial College London Diabetes Centre. This is just to reflect that we've moved from 1 tablet or even 3 tablets until 1990 to a plethora of tablets that we can choose from, each of which works slightly differently. So the SGLT2 inhibitors I mentioned, and the reason I mentioned them is, as I said, they've changed the scenery in diabetes. This is one kidney cell, and normally what happens is all the glucose in our body leaks into urine, and is then 90% of it is reabsorbed. The SGLT2 inhibitors, the new tablets, block that, and therefore we leak glucose. And it's the effect of losing a 2-finger or 3-finger Kit Kat every day. So it helps reduce the blood sugar, it helps the person lose weight, and it also improves kidney function and reduces heart failure. So really good medication. Looking at injectable therapies, and again, we'll speak in general, but we'll speak about the important changes in 2022. So there are 3 main groups. Insulin we've had for a long while. There are short-acting insulins, long-acting insulins, and mixed insulins for people who will only take 2 injections a day, and we'll speak about it briefly. There are new medications called GLP-1 agonists. That is a hormone that's produced by the gut, and we'll speak in slightly more detail about it. It is the hormone that tells us that we have eaten enough, but it's also the hormone that tells the pancreas to produce insulin because we've eaten enough. So the benefit of that is it lets the body produce extra insulin, but it also reduces the amount of food we have. There's a similar hormone called GIP, and now the new kid on the block for 2022 is one that has both GLP-1 and GIP, and therefore has almost twice the effect. So if we speak about insulin, you'll be glad to see I'm not going to tell you all about this, but just to say this is when insulin was discovered. And up until 1980, we were still using animal insulins of various types. And then more recently, it's become human insulin, which is produced by PCR, a very clean method. And more recently, we've had many, many insulins appear. Insulin that is produced by our body goes directly into the bloodstream, into the target cell. But most people who take insulin treatment have to have an injection or a pump where they inject into the fat underneath their skin, the so-called subcutaneous space. That then goes into the bloodstream and goes to the target cell. The types of insulin we saw, and I'm not going to discuss them, there are some which are very short-acting. And historically, the long-acting wasn't really long-acting, it was about 18 hours. But now we have really long-acting insulins, up to 7 days. And this is the range of insulins that we use today in ICLDC. As you can see, this is far better than the previous option of having a needle and syringe and only 1 or 2 types of insulin. The way we would give insulin, so in a healthy human being, our body produces a small amount of insulin all the time, the so-called basal insulin. And when we see food, even before we eat, our body starts to produce insulin to settle the blood sugar. And people with type 1 diabetes, we try and treat with a similar program, a basal insulin or a long-acting insulin, and a short-acting insulin with each meal according to what the meal is. And this is called the basal bolus regime. There are other options. There are people who will take short-acting insulin with meals or very short-acting insulin with meals, as well as an intermediate-acting insulin, or they'll have it all in one injection, a pre-mixed injection, twice a day. And if you look here, that's how the short-acting insulins work, and these are the pre-mix. Our worry with these types of injections is there are areas of overlap which can result in low blood sugar, whereas this one has very little areas of overlap. So just to summarize our insulin treatment, people with type 1 diabetes can be treated through an insulin pump. I'll mention them briefly at the end, but there's not time for it today. We spoke about the basal bolus, the pre-mixed insulin and mealtime insulin, and rarely we would use this type of insulin if they've been using insulin for a long time and will only have 2 injections. With type 2 diabetes, often they will need only 1 injection, the basal insulin, and then with tablets, they're able to cope with the rest of the day. Or they can have 1 mixed one, which has short-acting and long-acting, and we give it with the main meal. And that, again, is one of the newer insulins, and we're very happy with it because for elderly patients, it's just 1 injection at lunchtime, and it fixes that high rice intake as well as the 24 hours. The new kid on the block, what's new in 2022, there is now a new long-acting insulin called icodec, which can be given once a week. And we envisage that that will completely change how we treat elderly patients who live alone. So up until now, we've been accepting that their diabetes control is not going to be excellent because no one can give them insulin. But actually, if it can be given once a week with a low risk of hypoglycemia, then their children who come on a Friday or a Saturday should be able to do that. So as opposed to a daily injection, this is a once weekly injection. I spoke briefly about GLP-1 agonists, and they, as we said, reduce appetite, they reduce the emptying of the stomach, they increase insulin secretion, and therefore they reduce the food intake, increase our feeling of fullness, and reduce hunger, as well as increasing insulin. So they result in weight loss, and sometimes very significant weight loss, up to 12% of the body weight. They have no risk of hypoglycemia because the insulin that is produced from the body is only in response to the amount of sugar that is already there. It's beneficial for people with heart disease, heart failure, and kidney disease. So in patients who have heart failure, heart disease, or kidney disease, it can actually be considered first-line therapy. And these are the types that we currently have. There are short-acting types, which are used twice a day or once a day. And there are long-acting types that are used once a week. Bidrone was very complex to put together, so it isn't very often used, but both Trulicity and Ozempic are used regularly and are very helpful in diabetes control, preventing side effects, preventing complications, as well as weight loss. There are also combinations of insulin and GLP-1 agonists, which can be given once a day. Again, really useful in the elderly population, but actually useful in people who will only take one injection. They reduce the blood sugar, fasting and after meals. They have no additional hypoglycemia. They're weight neutral or cause weight loss, and it's a once daily injection. And this is the new kid on the block, which is a combination of both a GLP-1 agonist and a GIP. The only thing I want to show you is it significantly reduces blood sugar and it significantly reduces weight. So this, in less than a year, is loss of 12.5 kilograms. And we now know that in a year and a half, it's about loss of 22 kilograms, so very significantly. I'll move on to technology in diabetes, and I believe that technology has been a huge asset in diabetes care, in monitoring and in treatment, and I will not speak about it, but actually in telemedicine and telehealth. So over the time of COVID, it has been fantastic to be able to speak to people whilst they're at home, be able to download their meters, see what they're doing, send them the medication home. It really has been a game changer during the times of COVID, and we still use it. So moving on to monitoring. So just to speak about glucose meters, the normal glucose meters where people test their blood sugar using their fingers, the newer forms can now be downloaded. When people test, the meter itself can provide information saying high blood sugar, please test ketones, or low blood sugar, please go and have a meal, or really low blood sugar, please have a sugary drink. Flash glucose monitoring, or Freestyle Libre, is a new method whereby people can use a stick-on sensor onto their arm, and this lasts for about 2 weeks. They can then scan it either using their own phone or using a small reader, and this not only tells them what their blood sugar is, it also tells them, is their blood sugar going to rise or is it going to fall? It's really helpful when they come to see their physician, because it tells us how long they've been in. We can download 2 weeks worth. We can see if they're scanning regularly. We can see what their 3-month average is. We can see how long they've been in the target range. Have they got significant hypoglycemia? Do we need to ease back on their medication? Or do they have very high blood sugars? Really helpful. It also shares this profile that we can tell patients, actually, you're fine until you have breakfast or dinner. You're not having enough insulin with that. And because it gives us 2 weeks, we can actually discuss that this is a trend and not just a one-off. So it has changed completely how we measure blood sugars. I think in the past, not testing at all has been like driving with your eyes closed. And now, with sensors, with continuous glucose monitoring, we're driving with our eyes wide open. There's also smart pens or insulin pens that can remind you what the last dose you took. They can help you calculate if you're going to eat a particular amount, how much you need. They're particularly useful for parents of young children or for elderly people, because we can then download the record and that helps us in monitoring. And finally, there are the insulin pumps, and we've moved through lots of generations. The current type that we use is really helpful because we can monitor if someone gets low blood sugars. It will not only send an alarm, but also it will suspend the insulin, so people do not have dangerously low blood sugar for too long, which can affect brain function or even worse. And what we're looking for is what's called a closed loop. So at the bottom right, you will see that there are now sensors that speak to the pump, allow it to inject with each meal, as well as the basal, and to suspend if the blood sugar goes low. And that's the dream of every person with type 1 diabetic, to actually receive insulin without having to think about it. And that is now not a future, but is actually available and coming to the UAE soon. So can we prevent type 2 diabetes? Or if I get type 2 diabetes, can I get rid of it? Can we induce remission? So, looking at prevention, we actually have data from a long time ago from the Diabetes Prevention Program, telling us that if we change our lifestyle with diet and structured exercise, we have a very good chance of preventing diabetes. So this is the risk of diabetes in 10 years if we do absolutely nothing. And this is if we give people metformin, which is actually a diabetes treatment, and this is lifestyle. So actually lifestyle is better than an anti-diabetic treatment if we're able to maintain it. If you are Finnish and people from Scandinavia are very disciplined, you can reduce your risk of getting diabetes by 40% or more. And actually, with a dietary intervention, almost 60% reduction in the incidence of diabetes if you follow a structured program. Again, is it particular to people who are Caucasian? Well, no. They've looked in China, and the Daman has the highest number of patients allocated to any of the programs. And over 6 years of intervention, there is a huge reduction to people who have diet and exercise in a structured program. They had a far reduced risk of diabetes. And actually, even when they stopped the program, there remained a difference 20 years later. So you can see that the curves look similar. There's still an increase in the rate of diabetes, but stopping it early actually helped them long term, and therefore the complications are reduced and everything else. Can we do it with anti-obesity drugs? We said that diabetes and obesity are best friends. And yes, we can. So Xenical or Orlistat is one of the weakest obesity treatments. Yet even with that, and what it does is it sucks all the fat out of diet, and so it is not absorbed. The weight loss with it is actually not very significant. There's only about 4 to 5 kilograms, but even then it reduces the risk of diabetes by about 45%. And this is in patients who have pre-diabetes, and this is even in all patients, those who have impaired fasting glucose or have normal glucose today. The reduction is still well over a third. This is looking at a higher potency medication, which is a combination of phentermine and topramate done in the US, so-called Kismia. And in the lower dose, there's a 54% reduction in the incidence of type 2 diabetes every year. And in the higher dose, there's a 3/4 reduction. Liraglutide, or Victoza, as is commonly known, reduces the risk of developing diabetes by about 80% in patients who have pre-diabetes. So there's a theme. If we manage to reduce the weight, and Victoza is one of the most potent ways of doing that, in people with diabetes, then you reduce the risk of developing, people with pre-diabetes, you reduce the risk of developing diabetes. With a GLP-1 agonist that is oral, that is now available, we also get similar reductions and remission of type 2 diabetes, resolution of type 2 diabetes. Other forms of resolution of type 2 diabetes, we've known now for almost 20 years from the Swedish obesity study that people who undergo bariatric surgery have remission of their type 2 diabetes, where all the results are exactly the same as a healthy person in over 70% of people at 2 years, and over 30% of people even 15 years after surgery. And this is just the Stampede trial, another very similar trial, saying that if we look at people with diabetes already and compare them with those on medical therapy, then the reduction in diabetes medication is about 2/3. Not only can we get rid of diabetes in people who've had diabetes, often these are people who have had diabetes not for a long time, who don't need insulin, but actually in anybody who has diabetes and obesity, there is a significant reduction in the medication they need, and there is a significant reduction in the number of people who need no medications at all. So almost 60% will need no medication at all. So this is just another way of seeing it. But what I would like to say is that if you look at people, for example, who have a gastric bypass, 3 years after their operation, 45% will have no treatment at all, another 14% will only need one treatment. And as opposed to almost 50% needing insulin, only 12% will need insulin. So weight loss is a very good treatment, and for both remission and reduced medication So can we do this with just lifestyle? We know we can do it with tablets. We know we can do it with medication. And this changed about 2 or 3 years ago in the UK. This was done by general practitioners out in the community where people were given a very low calorie diet and some education on how to use it, but really pretty much was done by the human beings themselves rather than by constant control by medical physicians. And sure enough, in people who had diabetes within the last 5 years and did not require insulin, there was 45% in the first year, just with a dietary intervention, had no diabetes. And by the second year, about 35%. And actually now that they've looked at different subgroups, we know that if people manage to lose 15% of their weight or over 15 kilograms, 80% of them will have no diabetes. They will have remission of diabetes. So today, our target is to tell people to lose 15% of their weight if they have new onset diabetes within the last 5 years. And it is likely that they will not have diabetes at least for a time. They will be in remission. So I think in summary, not that I believe in the ape theory, but this was one of the Economist's front covers showing how a human being has developed and then has become or the majority of people in the world have become obese. We've now shown by diet, by medication, anti-diabetic and anti-obesity, and by bariatric surgery that we can prevent diabetes, and even in people who have developed diabetes, induce remission. In conclusion, diabetes, and particularly type 2 diabetes, is a global burden, and early effective management prevents complications, it saves lives, it improves the quality of life and productivity. So in the long run, treating early saves money. It saves the person money and it saves the country money. Therapies have progressed greatly in the last 10 to 20 years, and I hope that you have appreciated some of that change. Excellent diabetes control and diabetes remission are achievable now with the newer agents, and they have reduced side effects, and therefore we feel happier using them. There are added benefits on heart disease and kidney disease, and selecting the right treatment for the right patient is key. And thank you very much for listening.
Thank you, Dr. Sara, for such an informative presentation around one of the common health conditions here in UAE. Now we will be moving to our Q&A sessions. So we have a question here. First question is, my father have been a type 2 diabetes for more than 20 years and have resulted with Parkinson's, same was my grandmother. Although I try to follow an active lifestyle, what further can be done to avoid this if it's genetic in the future?
Okay, so there are two things we're talking about here, the risk of diabetes and the risk of Parkinson's disease. I am not qualified to speak on Parkinson's disease. We know that vascular disease in the brain can be one of the causes of Parkinson's, and certainly preventing that is very helpful. So if you are young, you're healthy, you're doing exactly the right thing, lifestyle, screening, make sure that you do not already have diabetes or pre-diabetes. From a lifestyle point of view, the key bits of advice we spoke about, so make sure you walk for at least 10,000 steps every day. Make sure you put in 3 hours of an exercise that will build muscle. Make sure that you sleep adequately at night, and I cannot stress the benefits of that on not just diabetes risk, but cardiovascular disease risk and many other things. Make sure you drink 2 liters a day of water. And if you do develop diabetes, then go early, get the treatment, do actually stick with it. Because even people who have diabetes and are treated adequately have a far reduced risk of complications. And I didn't have the time to share that with you today.
And moving on to our next question, regarding the sweeteners like stevia, would you say it's recommended to use it for people with diabetes or also without diabetes?
So the short answer is if you can do without, do without. The long answer is sugar sweetened beverages are harmful. Sweeteners increase hunger. So we find one of the risks of weight regain or weight gain is sweeteners, because they give the body the false sensation of sweetness. Therefore, you crave a bit more sweet. If you're able to do without them, excellent. If you are moving from a very high sugar content, then sweeteners have their role to play to help you in that transitional area.
Great. And moving on, what class of drugs does glimepirides fall in? I take one tablet glycomid GP half milligram every morning before breakfast and one tablet metformin 500 mg SR after dinner. Is this safe to take on a long-term basis? With this medication, my fasting blood sugar is 105 and 2-hour postprandial level is 1 to 25.
So the first thing to say is congratulations, you've got excellent diabetes control. Well done. About the specifics of treatment for a particular person, I don't think it's fair to discuss that. I think it's probably sensible to speak with your doctor. The class of glimepiride is called a sulfonylurea. It's a very old class of medication which works very well. In people with genetic forms of diabetes, it's probably the best treatment. But depending on what type of diabetes you have, what other risk factors you have, there may be better treatments for you. Metformin remains the basis of treatment for all diabetic patients. It's cheap, it's safe, it has other benefits, it doesn't cause hypoglycemia, it is weight neutral, it reduces the risk of many things, including cancers. So it's a beautiful medication. Actually, I'm changing my mind a bit, but it's all this and it's still very good.
Good. And are statins safe to be taken on a long-term basis for type 2 diabetes?
Absolutely. So we did not have any time today to discuss treatment of high blood pressure or treatment of cholesterol. Statins save lives. Unfortunately, there's a lot of bad press about statins, and if you're following WhatsApp rather than your physician, then many patients stop their statins for vague reasons, including apparently effect on memory and all sorts. Statins reduce cardiovascular risk by 40%. So they reduce your risk of a heart attack or a stroke, which often is a cause of poor memory, by about 40%. They are very safe long term, and everyone who is eligible to have a statin should have it.
Great. And for patients with type 2 diabetes who are suffering from loss of weight below normal while using metformin as the only anti-diabetic medication, what would be the best anti-diabetic that does not lead to weight reduction?
Okay, so this is again something that we only see in this region. People are quite keen to maintain their weight. It is far more important to look at the health than the number of the weight. But I take what you're saying. There is a small percentage, 10% of people are very lucky. In them, metformin is a very potent weight loss medication. That is a genetic thing. Most of us would wish they had it, but some of the people who have it see that they are underweight on the metformin. There are treatments which will put on weight and have added benefits. And again, please discuss with your physician that pioglitazone being one of them, or excuse me. I think, first of all, discuss with your physician, have your weight measured, make sure that it really is below where you want to be. And then if necessary, I'm sure they'll be happy to offer you medication that will help with that.
Great. And doctor, regarding diet, would you recommend intermittent diet or fasting for diabetes?
So that's an excellent question. Again, we didn't have time to discuss different diets. It's intermittent fasting done properly. So the most popular form of intermittent fasting is what we call time-restricted feeding. So people eat within 8 hours of the day and then only drink water or black tea, black coffee, things that have no calories in them for the rest for 16 hours. And as we spoke about the circadian rhythm or the hormones actually working better during the day, intermittent fasting that works best is that where you have breakfast and lunch, and then you have nothing in the evening. And in that situation, it does cause marked reduction in insulin resistance and can improve diabetes. It is actually one of the options we give people in our diabetes remission clinic. So people can choose a low carb diet, a very low calorie diet, or intermittent fasting. It does work.
And on this topic about diet, is there a certain type of food that reduces sugar level naturally?
So there are two questions in there. Are there foods that reduce your blood sugar naturally? foods other than rapid acting carbohydrates reduce your blood sugar naturally. So if you use protein or fat, that will reduce your blood sugar naturally. So if you're having an insulin injection, for example, and eating something that's mainly protein, you do not need insulin or not as much insulin. The other part of that question is, are there herbs or over-the-counter medications or that I can use to treat my diabetes? I think the current answer is God only knows. Allahu alim. But if you are going to try anything, please do not stop your medication. Please take your medication. Please do not risk taking things that are not understood. So if you want to take, for example, a known herb, cinnamon, whatever, please do take it. But please do not buy over the counter a mix of herbs. You have no idea what they are, because we've had people who've had kidney disease and serious illnesses. Please do not import things through the internet that might be harmful for you.
And regarding the HbA1c test, if someone had like blood issues, so will be the HbA1c a correct result for diabetic patient?
That is an excellent question. So in the UAE, we have quite a significant number of people who will have thalassemia or sickle cell traits, where their red cells do not last for 3 months, or even G6PD, anemia tafawul, where their red cells get broken far more regularly than the 3 month, and therefore, even if their blood sugar is high, their HbA1c will be low. Similarly, we have lots of people who have iron deficiency, and in them, their HbA1c may be high, even if their blood sugars are better controlled than the HbA1c. So we have special tests that we can use. Now that we have the freestyle sensors, certainly for type 1s, it makes our life much easier, because that gives you a calculated one based on the glucose itself. Anybody who does an HbA1c without getting a full blood count cannot really tell you what that HbA1c means. So this is across the world, everybody gets a full blood count. And if we realize that there is a discrepancy between your meter and your HbA1c, we then go on to do other tests, such as a fructosamine. That's an excellent question.
Great. And someone is asking, I wanted to ask if long-term use of continuous glucose monitoring could contribute to raised anxiety in certain patients and result in the opposite effect of the intent of monitoring.
Yes. So like everything in life, even and the analogy I used was driving a car. There are some people who will never sit on the front seat because they don't want to see what's on the road. They will always sit in the back seat.
Yes.
They can never be the driver. So if one wants to be in control of diabetes, sometimes we will encourage seeing a psychologist or having cognitive behavioral therapy to try and help them be the driver, be able to use that sensor as best as they can. However, if they really can't, and if it really is stressing them out, they will just have to be a backseat driver. It's whatever works. Every person is individual, whatever works. However, if someone said to me, you can have a Ferrari if you learn to drive, I probably will learn to drive.
Great. And doctor, in case of traveling, how can I preserve insulin?
Excellent question, another excellent question. So traveling, there are two things. So preserving insulin is not hard. One of the reasons I can say that is the pen that you are currently using, or the person is currently using, doesn't even need to sit in the fridge. If you are able to tolerate the room temperature, the insulin is able to tolerate the room temperature. So for your flight, if you have one of the boxes, like the children's boxes for a lunch box with maybe an ice pack, that should take you to most places. If you're going to go and stay in the desert for 2 weeks in the middle of summer, most people don't do that, then it's slightly different. You do need to have to worry about whether the insulin will spoil or not. And similarly, if you're going to the North Pole, you need to worry about them. But in most places, carrying the insulin isn't a problem. You do need a letter to say that you're carrying insulin, that you're carrying medication, that you've got a sensor on, because it just makes your life a lot easier at the airport. The other thing to say is if you are going to a warm country and you're taking injections, please reduce your dose, because the bigger veins will absorb more. And if you're going to a cold country, you may need to increase your dose because you don't absorb as much, and therefore your blood sugars will be higher.
Great, great. And doctor, our last question for the day, how long will it normally take for HbA1c to lower from 12 to 7?
It depends on what the treatment is. And so really, we should be, in people with an HbA1c of 12 or over 9%, really we should not be waiting for the 3 months. We should be seeing them within a month or 2 months. We do see people who do manage from 12% to 7% within 3 months. We do. And it's often people who didn't know they have diabetes, were on sort of 2-3 liters of Coke a day, and it's as much the change in lifestyle as the medications that gets us there.
That's great. Thank you, doctor. This is the end of our Q&A session. We try to take questions as much as we can. Thank you, Dr. Sara, for your valuable input, really.
Thank you very much.
Thank you. Dear audience, Daman is dedicated to encourage the public to stay healthy and fit. That's why we are inviting you all to join Daman Challenge. Registration and more information can be found on Daman Insurance Instagram account in Daman Insurance Instagram account. Thank you again all for joining us today. Looking forward to meeting you all in our upcoming webinars. Stay safe and enjoy the rest of the day.